Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everybody. Today presentation we will talk about drug-drug interactions and adverse drug reaction. It is a very common practice in therapeutics the use of several drugs in the same time. This is known as polypharmacy. If I take more than one drug in the same time, there is a possibility of there are two possibilities. First, that there is no interaction between drugs. In this case, I have no problem. The second possibility, that one drug will interact with another drug. One drug will interact with another drug. How it will do that? It will either increase the response of the other drug or decrease the response of the other drug. So the expected therapeutic response will be different. This is known as drug-drug interaction. So two drugs taken simultaneously, they will interact in each other. One will modify the effect produced by the other drug. Okay? So drug-drug interaction, if I take more than one drug in the same time and there is a possibility of interaction between these two drugs, will take place either at the pharmacokinetic site or at the pharmacodynamic site, as we know. Pharmacokinetic site, we mean site of absorption, distribution, metabolism, or excretion. Of course, the pharmacodynamic site is the site of action of the drug, whether it is receptor, enzymes, ion channels, or membrane bumps. So this is the goal of this presentation. We will know what are the types of drug-drug interaction first. We have to know second, where does it take place, whether at the pharmacokinetic site or pharmacodynamic site. And third, what will be the result? What will be the outcome of the treatment? The outcome of the therapeutic response or treatment. Okay? So that's what we will discuss this presentation. We also will speak about the adverse drug reaction and how we can differentiate them from side effects produced by drugs. So the first site, which is the site of drug-drug interaction, is the pharmacokinetic site. As we have said, is the pharmacokinetic means what the body does to the drug, starting from the process of absorption, and after absorption, when it reaches general circulation, it will be distributed to different parts of the body, including the site of action, and then it will be eliminated by the process of metabolism and or excretion. Therefore, we'll start first with the site of absorption as a site of drug-drug interaction. The very first thing we can think about is the delay of absorption by delaying of gastric emptying. Delaying gastric emptying. That means the stomach will not discharge its content to the intestine. In this case, the drug will stay in the stomach and it will not be delivered to the intestine where most of the absorption takes place. This happens usually with atropine-like drugs, anticholinergic drugs, atropine-like drugs, which are known as anticholinergics. These anticholinergics will inhibit gastric motility and therefore will delay gastric emptying, resulting in delay of absorption. Once the absorption is delayed, that means decrease in bioavailability of the drug. Bioavailability will be decreased, therefore will decrease in action. This is very common phenomena that atropine-like drugs or atropine-like action will result in delay of absorption and therefore delay in the action expected. A second possibility of drug-drug interaction at the site of action is changing the pH of the gastrointestinal tract. As we have said, drugs, they are present in the gastrointestinal tract as ionized or non-ionized. Ionized or non-ionized. We said that the non-ionized fraction is the fraction which can be absorbed, okay, because it is lipid soluble. Therefore, we said that the degree of ionization is controlled by the pH. Therefore, changing the pH of the stomach will either accelerate changing the pH of the intestine will either accelerate or delay absorption. Okay. Third phenomena we have to think about, or which can affect absorption, is chelation. Very known phenomena. Chelation. Chelation usually takes place between the drug and other cations like divalent cation like calcium or trivalent cation or whatever. This chelation will form a complex of the drug with the cation and this will prevent their absorption. Maybe the most famous example is tetracycline. Tetracyclines, they chelate with calcium, forming a complex which cannot be absorbed. Therefore, it is very common practice that any patient given tetracycline antibiotic, we will tell him not to take milk together with the drug. Therefore, this is the first site of drug-drug interaction, at the site of absorption. The second site is the site of distribution. We said that drug, once they reach the general circulation, they will be binded with plasma protein. Plasma protein binding. This is very famous site of drug-drug interaction. Some drugs, they bind highly with the plasma protein. So most of the drugs, 80% for example, is present binded, and only small fraction, 20% for example, is present free. We have said in a previous presentation that only the free fraction can be distributed. Okay, now in this case, what will happen if two drugs, they compete on the binding site? Suppose I'm taking drug A and drug B. Drug B and drug A, they bind to the same plasma protein. Bind to the same plasma protein. So what will happen? Drug B will displace drug A from plasma protein, increasing its free fraction. Increasing its free fraction means more of the drug is available at the site of action. More drug is available, that means more action. This can result in toxicity. This is very common the site of drug-drug interaction. The third side of drug-drug interaction is the site of metabolism. We have said that drugs are metabolized mostly in the liver through two phases: phase 1 metabolism and phase 2 metabolism. We said in phase 1 metabolism, drugs are metabolized by the cytochrome B450 enzyme by process of oxidation or reduction. We have said that phase 2 drugs usually they are conjugated with different molecules, process of conjugation. We have said that in cytochrome B450, which is responsible for metabolism of many drugs, are exposed either to stimulation by drugs, which we call it enzyme induction, or by inhibition of drugs. Drugs either destimulate cytochrome B450 or inhibit cytochrome B450. If they increase, this is we called it induction. If they stimulate cytochrome B450, they will increase their own metabolism and metabolism of other drugs, because as we have explained before, the enzyme will be active and in high concentration. So therefore they will increase their own metabolism and the metabolism of other drug as well. The most famous example, for example, are barbiturates. Barbiturates, they are very strong enzyme inducers, and that's why one of the reasons why they are not commonly used nowadays. Plus, for example, carbamazepine. Therefore, if two drugs are taken, we expect that the second drug metabolism will be accelerated and therefore its action will be reduced. Some drugs, they are inhibitors of cytochrome B450. And most famous examples are the macrolide antibiotics like erythromycin, and clarithromycin. These are antibiotics which inhibit cytochrome B450. Maybe the most famous interaction between these antibiotics is with warfarin. Warfarin is anticoagulant fibrinolytic, which is used for treatment of thrombosis. Therefore, these drugs they inhibit the metabolism of warfarin. Warfarin will be accumulated in the body, resulting in hemorrhage. This is very famous drug-drug interaction. Therefore, drugs which are people or patients who are given erythromycin or clarithromycin, they should not be given warfarin and vice versa. Second example of drugs which inhibit, there are many examples of inhibitors. We will take them inshallah when we will talk about groups which are used in systemic pharmacology. Azole derivatives, very famous, like ketoconazole or fluconazole, for example. Ketoconazole. All these azole derivatives, they are very famous inhibitors of microsomal enzyme, and therefore they inhibit the metabolism of other drugs taken in the same time. Ketoconazoles, they are famous in their interaction with verapamil. Verapamil is calcium channel blocker, which is used for treatment of different types antiarrhythmic drugs and treatment of ischemic heart diseases. It has several clinical uses, as you will see later. Azoles will inhibit the metabolism of verapamil, increasing its toxicity. A third site of drug interaction at the pharmacokinetic site, the fourth site of drug interaction at the pharmacokinetic site is the site of excretion. And we have said that drugs usually they are excreted through the renal system, renal sites, renal excretion through glomerular filtration and active tubular secretion. Active tubular secretion. Most of the drugs, 80% of most of the drugs that are excreted by active tubular secretion. Therefore, if another drug will inhibit this active tubular secretion, it will increase the level of that drugs in the body, leading to toxicity. Maybe the most famous example is digoxin. Digoxin tubular excretion is inhibited by many drugs like erythromycin, clarithromycin. Erythromycin will inhibit the renal tubular secretion of digoxin, increasing its blood level and therefore increasing its toxicity. Second example, well-known example, is propenicid. Propenicid will inhibit the tubular secretion of penicillins. This is clinically used and therapy where propenicid is used to increase the level of penicillins in the body. Also, changing the pH of the urine, changing urine pH will affect renal excretion of drugs. And we have said that most drugs in the urine, they are present as ionized and non-ionized. And non-ionized will be reabsorbed through the renal tubules back into the general circulation, while the ionized part will be excreted in the urine. We have said that changing the pH of the urine will affect the degree of ionization, and therefore it will affect how much of the drug will be excreted and how much will be absorbed. Maybe the most famous example, as we have said before, is aspirin, acetylsalicylic acid, where its ionization is increased in alkaline urine, which can be done by giving sodium bicarbonate. So therefore, sodium bicarbonate will be expected to increase elimination of aspirin, as we have explained in previous presentation. Okay. Now, so this is the sites of drug-drug interaction at the pharmacokinetic site, either at the site of absorption, at the site of distribution, at the site of the metabolism, or at the site of excretion. Second site of drug-drug interaction is the pharmacodynamic site. Pharmacodynamic drug-drug interaction. And by pharmacodynamic, we mean that drugs interact at the site of action. These drugs, they either increase the effect of each other, they increase the effect, one drug will increase the effect of another drug at the site of action, or decrease the effect at the site of action. It depends on the kind of interaction, as we will say later. Okay? The first type of drug-drug interaction is the what's known as pharmacological antagonism. Pharmacological antagonism. Pharmacological antagonism we have already discussed in a previous presentation, and we divide them into competitive antagonism and irreversible antagonism. In this case, we have said that two drugs, they act on the same receptor. One will act as an agonist and the other one will act as an antagonist. The antagonist will prevent the access of the agonist to the receptor, decreasing its action. This is drug-drug interaction, and it has very important clinical application, as we have said previously. The second drug-drug interaction site is what's known as physiological antagonism. Physiological antagonism, when I have two drugs, drug A and drug B, they act on different receptors. Each one acts on its own receptor. They act on different receptors and producing opposite effect, producing opposite action. In this case, for example, drug A produces a decrease in blood pressure and drug B produces an increase of blood pressure. So we have two drugs, drug A and drug B. Drug A acts on its own receptor, producing a decrease in blood pressure, and drug B will act on its own receptor, producing increase in blood pressure. That's why it's known as physiological antagonism, physiological, because they produce the opposite physiological action. Maybe the most famous example is histamine, which acts on H1 receptor in blood vessel, producing vasodilatation. This vasodilatation will result in decrease in blood pressure. So histamine will produce decrease in blood pressure by acting on H1 receptor blood vessel, producing decrease of blood pressure. Another example which increases the blood pressure is adrenaline. Adrenaline is adrenergic drug, which we'll talk in details about later, inshallah, which acts on alpha receptor on blood vessel, producing vasoconstriction. Vasoconstriction. This vasoconstriction will result in increase of blood pressure. Okay? That's why adrenaline, it is used in treatment of anaphylaxis, as we will discuss later, inshallah, when we talk about adrenergic drugs, because in anaphylaxis, histamine will cause very severe vasodilatation, which can lead to shock and which can be reversed by giving adrenaline. Okay. So this is when antagonism. Second type, instead of antagonism, one drug will increase the effect of another drug. If I take two drugs at the same time, one drug will increase the effect of another drug. In this case, we have four types of drug augmentation effect. The first is known as drug summation effect. What does it mean, drug summation effect? In this case, if I have two drugs, drug A and drug B, drug A produce one effect, drug B produce two effects. The final effect will be summation of both effects. Final effect in this case will be 3, for example. Okay, final therapeutic effect is summation of the effect of each drug. This summation effect, they call it summation when both drugs they act by different mechanism, Each one acts by different mechanism. Maybe the most famous example is the combination of codeine and paracetamol in treatment of pain. Analgesic مسكن. Okay, this is very famous combination. Therefore, a drug can increase the effect of the drug by summation. Summation, what does it mean? Means the sum of the responses produced by each drug, which acts by different mechanism. For example, codeine, which acts on opioid receptor, and paracetamol, which acts through the prostaglandins. A second type of mechanism which will result in an increase in the effect of the drug is known as drug additive effect. Drug additive effect. Drug additive effect. Drug additive effect, in this case, both drugs they act by the same mechanism. It's different from drug summation, where both drugs they act by different mechanism. In this case, both act by the same mechanism. They belong to the same group. Drug A, drug B, plus drug B. Drug A will produce one effect, for example, and drug B will produce, for example, 3 effects, and the final effect is the additive of both drugs will be 4. Final response will be 4. This is known as drug additive effect. Therefore, drug additive effect, when we take two drugs, they act by the same mechanism and they produce the same effect, and the final effect will be the additive effect of each drug. Maybe the most famous example is use of paracetamol plus aspirin as a mixture. Paracetamol plus aspirin. The third type of stimulation is what's known as drug synergism or supra-additive effect. Drug synergism or supra-additive effect. In this case, if I have two drugs, drug A and drug B, both of them they act on the same direction by same or different mechanism, doesn't matter. So two drugs they act on the same direction, for example, producing analgesia, but the final effect is more than the summation of each response produced by each drug. So, for example, drug A produces one response, drug B will produce two responses. The final effect, for example, is 5. Final response. This is known as synergism. Therefore, synergism, the final effect is greater than the responses produced by each drug alone. Okay, this is very famous, where barbiturates, for example, their effect is greatly increased by alcohol or the benzodiazepines. Benzodiazepines, they are anxiolytics used in treatment of anxiety alone, they never produce loss of consciousness. They never produce general anesthesia. Whatever the dose taken, they are very safe. They have very large therapeutic index. But when they are mixed with alcohol, when alcohol is taken with benzodiazepine, what will happen? This will lead to loss of consciousness, general anesthesia, which is very dangerous, can kill. Okay? This is known as drug synergism. So that's why it's called supra additive. So drug synergism, when the final effect exceeds the effect produced by each drug alone by many times, maybe 2 times, 10 times, 20 times. It depends on the type of synergism. Third type is known as drug potentiation. Fourth type, sorry. Fourth type is known as drug potentiation. Drug potentiation, when we have two drugs, drug A, drug B, drug A with an effect, or drug B with no effect. Okay? Now, if I take drug A alone, it produces one response, for example. If I take drug B alone, it will produce no response. The response is zero. But if I take drug B with drug A, I will get 2 or 3 or depends. I'll take more response. This is known as potentiation. I'll get more response from drug A. This is known as potentiation. Okay. Therefore, potentiation means one drug will potentiate the effect of the other drug, resulting in a final response of greater than that produced by the drug itself. Maybe the most famous example is the addition of glavulanic acid. Glavulanic acid, which is glavulanic acid. It is beta-lactamase inhibitor. It is added to, it has no effect on its own. But when it is added to amoxicillin, it increases the effect of amoxicillin, which is a beta-lactamase sensitive antibiotic. So these are the possible sites of drug-drug interaction at the site of action. So, what will be the outcomes of drug-drug interaction? There are either good outcomes of good clinical benefit, and these are used usually clinically, as we will see in a few minutes. Or there are bad outcomes. Clinical outcomes will be bad. In this case, can lead to a process known as adverse drug reaction, as we will discuss in a few minutes. Okay, so let us first talk about the beneficial effect of drug-drug interaction. So, clinical uses are many, but I will just discuss few of the most important clinical application of drug-drug interaction. The first clinical application, which is used clinically, is to enhance the therapeutic response by using smaller dose of the two drugs. to enhance the therapeutic response. Suppose I'm using drug A and drug B, and both of them they are analgesics. They are used to treat pain, for example. So I can use each drug in a smaller dose. In this case, smaller dose means less side effects of each and less possibility of toxicity. Okay, this is the first clinical application, is to enhance the therapeutic response obtained from each drug by using smaller doses of each. Maybe the most common examples are the codeine mixture with paracetamol. This is very common combination which is used for treatment of different types of pain as analgesics. Okay. The second famous example is the use of two different groups of drugs in treatment of hypertension. For example, the combination of beta blocker plus diuretics, as well the use of ACE inhibitors like lisinopril plus diuretics. This mixture of drugs usually they will produce higher therapeutic response with less doses of each drug, therefore decreasing side effects and decreasing toxicity. This is one first important application of drug-drug interaction. A second application is to use two drugs acting by different mechanisms for the treatment of one disease. Therefore, mixing drugs acting by different mechanisms to treat one disease. For example, in the treatment of myocardial infarction, the treatment of myocardial infarction, MI, we use, for example, antiplatelet aggregatory drugs, antiplatelet aggregation like aspirin. Aspirin will prevent platelet aggregation, therefore prevent thrombus formation. And as we use warfarin, which is a fibrinolytic. It dissolves the thrombus. So this is the most common second application. Another example is by the use of beta 2 agonists, which are bronchodilators, plus corticosteroids, which are anti-inflammatory. This combination is used in treatment of bronchial asthma. Therefore, I will get the beneficial effect of producing direct bronchodilation by relaxation of the smooth muscles, the bronchioles, and by producing anti-inflammatory effect, which is very common feature in bronchial asthma. The third example of clinical application of drug-drug interaction is the combination of antibiotics. We use different antibiotics which act by different mechanism of action in order to delay resistance, bacterial resistance delay bacterial resistance. This is very common application, especially for the treatment of tuberculosis. The fourth clinical application, which is one of the most important, is some combination are used for synergistic effect, to get very strong response, as for example the mixture of sulfa methoxazole and trimetoprim as antibacterial drug. This mixture is known as co-trimoxazole, very famous. Trimoxazole, very famous mixture. Okay. Also, anti-cancer drugs, they are combined for synergistic effect. Especially, for example, there are many. The use of cisplatin, plus paclitaxel. So these are the most important clinical application of drug-drug interaction, of useful drug-drug interaction. Okay. Drug-drug interaction can result in what's known as adverse drug reaction. So now we are going to talk about adverse drug reaction and how we can differentiate them from side effects. Okay, side effects and adverse drug reaction are completely different terms, which means different things, although they are used interchangeably by mistake. So we know that drugs, they produce several actions. They can produce drug, for example, action A, action B, action C, and action D. One of the action is desirable action, is the desirable effect. This is what we want. This desirable effect is known as the therapeutic effect or therapeutic action. For example, I use aspirin for treatment of headache. So the analgesic effect of aspirin is the therapeutic action. The other action produced by the drug are known as side effects. Okay. Therefore, side effects are the undesirable action produced by drugs, and usually these undesirable effects, they appear in all patients taking the same drug. This is common. Let us take very famous example. For example, let us take example of antihistamines, first generation antihistamines. First generation antihistamines, H1 blockers, they block the H1 receptor and they are used in treatment of different types of allergy. Besides blocking beta H1 receptor, they block muscarinic receptor as well. They have anticholinergic effect. They block muscarinic receptor. This blocking of muscarinic receptor will result in what was known as atropine-like side effect. Atropine-like side effects. This includes, for example, constipation, dry mouth, blurred vision, many. Okay? So, antihistamines, they have a therapeutic application in treatment of allergy. Besides that, they can produce side effects. Okay? These side effects they are not dangerous. They don't necessitate stopping the treatment. They don't hinder the treatment. They don't stop the treatment. The treatment can go on. But of course, the patient usually they don't like side effects. And these side effects will decrease the hindrance of the patient to the therapy, will decrease compliance. Okay? So side effects usually they are common with most drugs used. Adverse drug reaction they are different. Adverse drug reaction they are different. Usually adverse drug reaction can result in hindering treatment. It can result in stopping of treatment. Stopping treatment. Why? Because usually they are more serious and more toxic than side effects. They are more toxic. Okay? Adverse drug reaction, there are many. They have been classified into about 5 types. But I'm going to talk only about 2 types. Type A, adverse drug reaction, and type B, adverse drug reaction. And what's the difference between each? Okay? Type A, adverse drug reaction, usually they are extension of pharmacological effect. As we will take in a few moments. Pharmacological action extension. For example, I take warfarin to prevent blood clotting. Warfarin as anticoagulant. I take it as an anticoagulant. If I take a large dose of warfarin, can lead to hemorrhage. Okay? Hemorrhage is the adverse drug reaction because it is very serious. It can lead to death. Okay? So in type A, usually the adverse drug reaction, they are extension of pharmacological action. And we have taken the example of warfarin, which can lead to hemorrhage. Well, hemorrhage is very dangerous. And we have talked that warfarin metabolism can be delayed by drugs which inhibit the cytochrome B450 in liver, and they will result in adverse drug reaction. Okay. Another type, they are not extension. Type B is not an extension. So we said type A as an extension of the pharmacological action. Type B, on the other hand, is not an extension, of pharmacological action. Usually, it is an individual response to the drug. It doesn't happen in most of the patient. It happens in specific individuals. That's why it is also known as idiosyncratic reaction. Idiosyncratic reaction. Idiosyncratic is an individual response to the drug. It doesn't happen in all patients. It happens to specific patient. Okay. Therefore, type 1 takes place as an extension of the pharmacological action. Type B is not an extension, and it is an individual response. It is known as idiosyncratic reaction. Usually, type 1, usually they are rapid in development. They take place while taking the drug. Type A, adverse drug reaction, they happen while taking the drug. For example, the hemorrhage produced by warfarin takes place while taking the drug. If the drug is stopped, that's it. Hemorrhage will stop. On the contrary, type 2 usually they are slow in onset. They are usually delayed, maybe for days, weeks, or even months after stopping treatment. This is second difference. Okay? So the second difference in type A, usually they are rapid in occurrence, they are rapid in onset. It happens while taking the drug, while type B usually they are slow in onset, which develops after days taking the drug. Why? Why? Because so third difference, type A is not immunological. It does not involve the immune system. While type B, it is immunological. It involves the immune system. That's why the reaction takes place delayed onset, because you have to take the drug. The drug will be considered by the body as antigen. It will form antibody to this antigen, and this antibody antigen reaction will result in the adverse drug reaction. Okay. This immune system usually it involves three important organs in the body. Involves the skin, which can result in different skin reaction, including urticaria and different skin reaction. Liver can lead to liver damage, and blood, different disorder of the blood. That's why type B is more serious, is life-threatening. It can kill the patient. Okay. So this is the third difference. Fourth difference in the treatment. Usually type 1 is treated by the antagonist. Treated by type A. Treated by stopping the drug, of course, first, stopping the drug, and giving antagonist. For example, in case of warfarin, we'll give vitamin K as an antagonist. In case of type B, usually there is no antagonist. It is treated symptomatic treatment according to the reaction that takes place. Okay? So these are the differences between type A and type B. Therefore, type A is less aggressive. It needs stopping the drug. The adverse drug reaction can be treated by an antagonist, and it is less life-threatening. On the opposite, type B is more serious. It is delayed in action. It is individual response to drugs. It can result from genetically determined effect, and the effect usually is delayed. Maybe we'll take few examples of drugs that can produce type B, drug reaction, adverse drug reaction. Type B. Type A, we have given example of warfarin. Type B example is carbamazepine. Carbamazepine is anti-epileptic drug which is used for treatment of epilepsy, and as well it has other uses as in trigeminal neuralgia. Carbamazepine some very few people can react to carbamazepine, and this can result in aplastic anemia, which is very dangerous, plastic anemia, and agranulocytosis. Carbamazepine as well can involve the skin and can result in skin rashes, skin urticaria. Another example is quinidine, which is used as antiarrhythmic drug, very famous. Class 1 antiarrhythmic drug, quinidine, can result in thrombocytopenia. Okay, so this is the adverse drug reaction. So we said that adverse drug reaction, they are very serious and they can lead to death, and we can be treated accordingly. So by this we have finished what we are talking about in the principles of pharmacodynamic. We have talked about the principles involved in drug-drug interaction and in adverse drug reaction, and we have differentiated between adverse drug reaction and side effect. So in summary, we can say that today we talked about types of drug-drug interaction, including pharmacokinetic type at the absorption site, distribution, metabolism, and excretion. We also talked about the pharmacodynamic interaction, whether they are pharmacological or physiological antagonism, or by the additive action or summation action or synergistic and potentiation when one drug will increase the effect of the other drug. We talked as well about the differences between the side effects and the adverse drug reaction. Our next presentation, inshallah, subhanahu wa ta'ala, we'll start talking about systemic pharmacology. Now we have finished the introduction of the pharmacokinetic and pharmacodynamic generally, which are the basis for understanding the effect of drugs on different systems of the body. And now, inshallah, we'll talk about action or effect of drugs on different systems. And in the next presentation, we will talk about cholinergic transmission. And after that, we will talk about drugs which act on the cholinergic system. I would like to thank you very much for your attention. If you like the presentation, please press like. Please subscribe to my channel. I hope that you stay in peace and harmony. Wassalamu alaikum wa rahmatullahi wa barakatuh.